Hello, everyone. Welcome to the second Jaeger Medical Key Opinion Leader Educational Webinar for 2025. My name is Herman Groepenhoff. I'm the Senior Clinical Scientific Advisor at Jaeger Medical, and I'm very pleased and even honored to host this second session in a row of Key Opinion Leader Educational Webinars, which we will have today. We have a fantastic topic lined up with even this time two key opinion leaders who will share their valuable insights about how to manage a modern PFT lab in 2025. And we asked this to medical doctors from the US because they published on strategies of the management of a pulmonary function lab in CHEST in 2024 in September. So you all can also read their very nice written publication. During this webinar, please feel free to ask questions during the session by the Q&A box. Afterwards, we will have 30 minutes for questions and answer the questions you already shared. This participation will enrich our discussions. Two important points regarding when you want to receive your accreditation points. You have to attend at least for 30 minutes, and in addition, you also have to fill out our questionnaire, which you will receive automatically after the webinar within, I think, 24 hours, but in a few days after the webinar. Thank you again for being here, and let's get started. So please take over my microphone. Looking forward to this.
Okay. Thank you very much for hosting, and thanks to everyone for attending. So my name is Tom DeCato, and I'm going to present the first half here. And on this slide, you can see overview of pulmonary function testing lab medical director duties, and this is going to more or less serve as our outline for today. And I'm going to talk about the first several things, and then I'll hand it over to Dr. Hegewald. But the point is that the main goal of the medical director is to obtain high quality tests in an efficient and cost-effective manner. And these are the specific roles and responsibilities. And again, I'm going to touch on the first few. So we'll talk a little bit about creating policies and procedures and updating these things. So that might include infection control, things such as getting results into the medical record and sent to referring providers in a timely manner, and just the standard operating procedures for individual tests, spirometry, lung volumes, diffusing capacity or transfer factor, etc.
Dr. DeCato, sorry that I interrupt, but I cannot see your screen. Maybe I'm
Oh no.
but
Let me reshare it. Sorry about that.
No worries. Yep.
Okay. I'm going to advance it here. You can still see it?
Yeah.
Okay. Apologies about that. So now that you can see the slides, this is the lab medical director duties. So I'm going to talk a little bit about policies and procedures. We'll talk about supervision, education of technicians. Being available to staff is an important component for questions that arise, concerns about testing, helping to troubleshoot instruments, for example. And then we'll spend a little time talking about oversight of a quality control program and what that entails, what that means. And lastly, for my part, selection of reference equations before Dr. Hegewald talks more about testing in the lab. This is just an example. As I was putting slides together, I was updating our methacholine challenge protocol. And so this is just sort of a screenshot of the top of the document, but it sort of, for me, is serving to discuss these policies and procedures, and different labs do this differently. For example, our methacholine challenge is about 3 pages long, our policy, but I've seen in some labs, they're 12 pages long. So the detail can vary. But I think it's important that you have these, and a great resource to help in creation of these policies is the American Thoracic Society has published a lab manual. I'll mention that in some other sections, but that's a great starting off point for some of these policies, or talking to people you know who maybe run a pulmonary lab, and not recreating the wheel. I'm a big fan of kind of using what's there, not recreating things. And the ATS lab manual is a great option. We also have, kind of separate from the policy, is a competency training that our technicians in the lab go through, and they have to train in the test and make sure they're proficient in it. So next, staff training and education. This is going to be, I think, pretty variable across the world, and it's certainly variable in the United States. Any sort of standardized training is really lacking. There's variability in exposure, and there's variability in on-the-job training. Historically, it's recommended that that you complete secondary education or high school education, have 2 years or more of college education, whereas the lab supervisor would have training on top of that, typically a bachelor's degree or higher in respiratory care, and several years of experience. It's also recommended they become a certified or registered pulmonary function technologist, which I'll mention a little bit more about, and have some education or at least experience in business. Historically, when you look, the duration of training that has been written about for folks is 6 to 12 months for just the common pulmonary function test, having 6 to 12 months of training, whereas training beyond that, 1 to 2 years, is recommended for sort of gaining competence to troubleshoot instrumentation. And these are numbers that have been published more recently, but when you look back sort of where that comes from, it seems to come from a single reference from 1986. And I can't say that I've seen variability in training, certainly. But there is literature that testing performed by skilled and knowledgeable technologists results in high quality testing. And again, that's our end goal, is to get really high quality testing. So this is important. And in North America, there is something called registered or certified pulmonary function technologist. And this is just a screenshot from their website, from the National Board for Respiratory Care. It's an examination that is taken, and there's a score delineation, and if you're above that score threshold, then you obtain the registered pulmonary function technologist, and if it's below that threshold, then it's the C, PFT. Okay, so I'm going to transition a little bit into quality control. And lab quality control, so this is the process of monitoring accuracy and precision of testing and of the instruments, that they're functioning as they're supposed to. And there's sort of two parts to this. There's mechanical methods, what we call mechanical methods, and then biologic controls or biocontrols. And I'll talk in a little bit more detail about these. But I wanted to mention overall what this is referred to as the quality management system. So quality control is part of the quality management system, which encompasses much of the stuff I've been talking about. So training personnel, monitoring competency over time, having systems in place to report test results, etc. And again, the ATS Pulmonary Function Lab Management and Procedure Manual is a great resource to help in this endeavor. The third edition was published in 2016, and there will be a fourth edition forthcoming. So since that time, there have been several updates to technical standards, etc., that will be reflected in that fourth edition. So back to quality control. Quality control tests an instrument to verify that the output is accurate and or precise. And so if that's not the case, then a repair or adjustment is needed. So again, calibration adjusts the output of an instrument to match a known input, whereas verification, which is a lot of what we do, confirms that the instrument accuracy is within those specified standards. And there's a lot to this. So this is a table from that review paper mentioned. The reference is down at the bottom left-hand corner there for you. And so this is just meant to briefly summarize for spirometry, for diffusing capacity, and for lung volume testings, in this case, the plethysmograph, sort of the quality control that's recommended or needed. And then lastly, at the bottom, it talks about biocontrol testing. And so digging into that a little bit deeper, for spirometry, verification is required at least daily with a 3-liter syringe, and that's done over a range of flows to ensure that accuracy is within 3%. You want to use an inline filter during this process. And of note, the 3-liter syringe in and of itself, that needs to be evaluated and looked at on a monthly basis and then recalibrated annually. And so usually what that entails is that your 3-liter syringe gets sent off back to the manufacturer, and they'll do that process for you. But that means that you need to probably have more than one of these around. So even in a small lab, you'll want 2. And in bigger labs, you will certainly have more than that. And then they'll take the syringe apart, replace damaged or worn parts, lubricant, etc., and verify the accuracy is within 0.5%. For diffusing capacity or transfer factor, that is a more complex test, with higher variability, and there are numerous specifications and standards related to the rapid gas analyzers, which most systems are, the majority are currently. And interestingly, you do perform spirometer verification, though when you look at it, they say the accuracy should be within 2.5% as opposed to 3%. So there's a little bit of discrepancy there. And for lung volume instruments, it's going to vary based on the method of testing. So for the plethysmograph, these things tend to be calibrated automatically. The system does that. And you want to do it on a daily basis, though, if you happen to be in a place where there's sort of larger swings in the atmospheric pressure or there's weather coming through that day, then you ought to think about doing it more frequently than that. And a volume calibration is recommended to be done with a thermal flask on a monthly basis. Biocontrol testing. So this is a way to check all aspects of the system and is a supplement to the other quality control that we do. These folks should be healthy, non-smoking individuals. They should have normal lung function at baseline and be able to be there to perform testing on a consistent basis. And the schedule of testing is debated, I would say. We kind of believe that for diffusing capacity, weekly is ideal, but every other week is acceptable, and then at least monthly for spirometry and lung volume testing. And really, this testing should attempted to be done within 2 hours the same day, same time of day. The person hopefully has a consistent diet and is not exercising on the day of test. And then if they're ill or there's injury, something's going on, then they should forego testing. And so again, depending on the size of your lab, this may include several people that are serving as biocontrols. And the other advantage of having biocontrol testing is it can serve as sort of a spot check if you're suspicious that something is not working properly with an instrument. And so it's real easy to track this data in an Excel spreadsheet. And historically, Westgard's rules have been applied. So that means that if you're above or below 2 standard deviations, that's what they call a warning, and 3 standard deviations is out of control. We sort of have transitioned to using Z-scores in recent times for this purposes, as opposed to strict Westgard's rules. And you can plot these using what's a Levy-Jennings plot, and that's a useful way to visualize these data points, and I'll show you that here in a moment. This is an example of some biocontrol data from Dr. Hegewald's lab. What is reflected here is the first 8 tests in white, so occurred after he got a new instrument. And so he did 8 tests in quick succession over about 4 or 5 weeks here. And then that was sort of the baseline data going forward that future controls were checked against. And so in green, these values all fall within, at this time, what was 3 standard deviations here, but I believe that 2 standard deviations is now used in their quality control. This is a Levy-Jennings plot. So this is a nice visualization of your biocontrol data. So in this case, this is also a figure from the paper. On the y-axis is the absolute value of DLCO for the biocontrol, and on the x-axis is the month and day the test was done. So this covers the year 2022, and you can see average is the solid black line across, and then 1.96 z-scores is reflected by the hash lines above and below there. And then lastly, I'm going to talk about reference value selection. So this, as you'll see here, is sort of a bigger topic and has been getting a lot of attention in over the past 5 years. Ideally, reference equations used would represent the population of the community being served by the lab. And in my opinion, ideally you would serve as your own reference value. But obviously we don't live in an ideal world, and instrument software typically includes numerous equations. So there's lots to choose from. And data has shown that inappropriate use of reference equations can lead to both underdiagnosis and overdiagnosis. And we've learned that there are other financial and human costs to this as well. Race and ethnicity is the primary example of this that has been at the forefront again over the past 5 years or so, but this has been described well before spring of 2020 when that sort of became a big issue that everyone was talking about and working on. And so this is an example from my lab. This is the last page of our PFT report. And on the far right, you can see predicted authors, and it shows us where each variable comes from. So Bowerman, it's kind of cut off there. Bowerman is GLI global reference equation. Hall down below is GLI lung volumes, and then Stanojevic is DLCO for GLI. But you can see there are other equations in here specifically for spirometry. And so on our report, we have some variables that are not recommended to be included on the report, but for transplant purposes, pediatric purposes, those specialists have wanted these variables in. And so, but per the 2017 statement on a standardized pulmonary function testing report, they wouldn't be included, like FEF 2575, for example. This is summarizing the differences between the recommendations from the ERS ATS between 2005 and 2021. So this is a nice summary table they have in that most recent interpretive strategies document. And I just wanted to highlight reference equations. So as of this new standard, it was published the last week of 2021 is when it came out. The recommendation to use GLI reference equations for spirometry, lung volumes, and DLCO. And at that time, they mentioned more emphasis on an incomplete understanding of the role of race and ethnicity on lung function. And this is a big change from the prior recommendation, which was to use race or ethnic specific equations, which was preferred over using adjustment factors. And in the US, NHANES 3 was recommended with no specific recommendation for Europe, and no specific recommendations for reference equations for lung volumes and DLCO in either place. And since spring of 2020, again, when race and ethnicity in pulmonary function has become a big topic, there's been several studies published. And just over 2 years ago now, the ATS published an official statement, race and ethnicity and pulmonary function test interpretation, excuse me. This was endorsed by the European Respiratory Society as well. And I just want to share a few key conclusions and recommendations. So these are the 8 from the document. I'm just going to mention here number 1 and number 2 for our purposes. So PFT labs should adopt a race-neutral approach to PFT interpretation using average reference equations. And number 2 is GLI Global is a recommended race-neutral equation. And so from GLI, we have GLI Global and we have GLI Other. So the difference between these is quite small. But statistically, the 4 groups, white, black, Northeast Asian, and Southeast Asian, were equally represented statistically in GLI Global, and they were not in GLI Other. And I just want to stress that for lung volumes and diffusing capacity, those GLI equations come from white populations, from white persons. And so we don't have the race neutral equations like we do for spirometry. It's important that you state the reference value used on your report. So I showed you the last page that shows where each variable comes from, but down below here you can see this is sort of the demographic information at the top of the first page, and you can see it says GLI Global. So up front you can see what is being used and applied. And this is certainly an evolving area of understanding, and I do anticipate there will be further changes in the future in how we approach this and how we do this. So I'm going to stop there and hand it over to Dr. Hegewald to continue.
Okay, thank you, Tom. Can everyone hear me? Yeah, this is Matthew Hegewald, and I'm from Intermountain Health and University of Utah. So I'm going to address some other important topics for a PFT lab medical director. So one is, what's the efficient and cost-effective use of a PFT lab? And that includes what constitutes a complete or a full PFT. And traditionally, that includes some combination of spirometry, pre and post bronchodilator, lung volume measurements, either by plethysmography, nitrogen washout, or inert gas techniques, and diffusing capacity. Some labs also include measurement of maximum voluntary ventilation, MVV, and the measures of inspiratory muscle pressures, MIP and MEP. And some also include measurement of oximetry at rest or with exercise. And the question is, are these tests necessary for all patients, or can we more selectively use these tests to improve efficiency of the lab and to reduce costs and to improve the patient experience? So first of all, is bronchodilator responsiveness testing required for all? So somewhat of a controversial area. So most common bronchodilator testing protocol includes 4 puffs of albuterol, 100 micrograms per actuation, with a 15-minute waiting time. Now, the ATS-ERS manual also states that a 10-minute waiting time is acceptable. So some use 10, some use 15, no real standardization of that. And the definition of a positive response at present is a change in FEV1 or FVC of 10% of the predicted value, not of the measured value. So it was a change in the guideline statement a few years ago. Well, should we use bronchodilator testing for everyone? So the pro bronchodilator responsive testing camp states, well, it's recommended by the ERS ATS 2019 spirometry standards, the GOLD report, and the GINA 2024 update. And patients with COPD risk factors, a couple different studies have looked at that, and between 7 to 27% will change from obstructed to normal spirometry following administration of bronchodilator. So this is theoretically, quote, excluding, unquote, a diagnosis of COPD if you diagnose COPD based solely on spirometry. Well, the anti-bronchodilator testing for all states that correctly that bronchodilator testing is really of limited value in distinguishing asthma from COPD. And one of the studies listed there, a big group of patients with asthma and COPD. In fact, more patients with COPD responded to bronchodilator than in the lab than did asthma patients. And bronchodilator testing is highly variable over time. Several studies showing that. So it's a variable phenotype, and it doesn't, importantly, it doesn't predict treatment response to inhaled steroids or bronchodilators in either asthma or COPD. I think most labs have a caveat in their lab stating that the presence or absence of bronchodilator response in the lab does not preclude clinical benefit with either bronchodilators or even inhaled steroids with chronic use. So what does our lab do? Well, we acknowledge that bronchodilator testing really may not affect clinical care in many patients, but we still perform bronchodilator testing in anybody who has any new patient referred to the lab where spirometry is abnormal. So either a obstructive or restrictive ventilatory impairment is suggested by spirometry. And then if asthma or COPD is suspected, so it's listed in the diagnosis code, or if they have symptoms suggestive of airways disease, asthma or COPD, such as dyspnea, wheeze, cough, chest tightness. So that's queried by our technicians. And we do exclude bronchodilator testing if the FEV1 to FVC ratio is normal, so it's above the lower limit of normal, FEV1 is greater than 100% of predicted. There's a study that looked at roughly 500 patients in a lab, and anybody who met these criteria were highly unlikely to respond to bronchodilator. So our lab excludes testing, and we have a statement saying that bronchodilator testing was not performed because the didn't meet these criteria. So what about lung volume testing? So lung volume testing, significantly increases time commitment and requires a higher level of expertise. So certainly lung volume testing is required for the diagnosis of a restrictive ventilatory impairment and also to identify hyperinflation, large lungs, and air trapping. Now, there's different ways of defining those. Large lungs, hyperinflation, and air trapping. There's a little bit of controversy around some of those definitions, but it's required certainly to make those to diagnose those abnormalities. And really the main indication for lung volume testing is to confirm restriction in a patient with a low vital capacity. So historically, we've known that 50% of patients with about 50% of patients with a reduced vital capacity will have a low total lung capacity if measured with plethysmography or nitrogen washout. And conversely, we used to think that a normal FVC was thought to exclude a low TLC with high reliability, approximately 90%, 98% rather. So that was the dogma until just more recently. And this was the spirometry-based PFT protocol suggested by the ERS-ATS standards. So starting with spirometry, if your ratio is normal, greater than the 5th percentile, then the FVC is looked at. And if that's normal, above the 5th percentile, that's a normal spirometry. If the FVC is low, well, that's possible restriction or a nonspecific pattern. So once again, restriction defined by a low total lung capacity measured with lung volume techniques, and a nonspecific pattern, or if you recall, is a normal FEV1 to FVC ratio, a low vital capacity, and a normal total lung capacity. So those patients need, if you have a low vital capacity, theoretically, need lung volumes to confirm that that restrictive ventilatory impairment is present. And then conversely, if you have obstruction and a low vital capacity, commonly that's just the low vital capacity is due to air trapping. i.e. a high residual volume, but lung volumes are needed to determine if there's a mixed, both obstructive and a restrictive disorder present. So this is historical. We looked at this. And where does this normal FVC rule out restriction, i.e. a low TLC, come from? Well, this often quoted paper in Chest in 1999, and you can see that a couple caveats that this included a white only population and white only reference equations for both spirometry and total lung capacity, which was needed to confirm restriction. So in patients with a normal spirometry, so normal ratio and normal vital capacity. Out of those patients, over about 1,100, only 30 or 2.7% had true restriction. So there was a discrepancy between the vital capacity being normal and the total lung capacity being low. So uncommon. So, it was thought that based on this study that, well, if you have a normal vital capacity, you don't need to perform lung volume measurements because it's unlikely that a restrictive ventilatory impairment is present. Well, so that was what we thought. And then recently what we've been seeing, I'll give you an example, and this is an example of our spirometry report. Now it differs a little bit from Dr. DeCato's report at Harvard UCLA in that we just list vital capacity, FEV1, the ratio. Now, we also list FEF 2575 in our report that, once again, the ATS ERS standards on reporting don't suggest that that's listed as very little. But I think, like Dr. DeCato, the lung transplant, the pediatric people, physicians that orders testing wanted that. Anyway, this is what our report looks like. We have a grade. We have the best flow volume curve, volume time curve, and we list the plot the z-scores here. So this is a FVC that is good quality study, first of all, but FVC is low, so it's negative 1.74 z-scores, so it's below the lower limit of normal, below the 5th percentile, 78% of predicted. Now, this is using what we used to use about a year and a half or so ago, the GLI race-specific equation that for whites and Hispanics. It's a 41-year-old white male. And then this is their DLCO testing results, and they had a low alveolar volume. Their alveolar volume reflects total lung capacity. It underestimates it. So alveolar volume plus a measure of dead space, usually used 150, basically approximates TLC. But that's low also. And the total lung capacity measured with pleth is low, also at less than 1.645 z-score, 78% of predicted. Remember, our FVC was 78% of predicted, and our TLC is 78% of predicted. Both are low, and this would be the criteria for what we call simple restriction, as the FVC and TLC are reduced in proportion. So just standard, what we would call restrictive ventilatory impairment. How you grade the severity is debated. Some will use TLC, some will use FEV1 to grade overall severity of impairment. But regardless, this is most would say, well, it's a restrictive ventilatory impairment. We have a low FVC, low TLC. Well, then a couple years ago, we changed. So we switched to the GLI global reference equation. And as we'll show you, this affected the FVC percent predicted in z-score for all the races. And for whites specifically, the FVC percent predicted is going to be higher. So remember, before it was below the lower limit of normal, 3.55 liters, negative 7 something z-scores, and 78% of predicted. Well, now the same patient using the GLI global is now normal. Their 85% are predicted negative 1.05 z-scores. So what happened? Well, this is a paper published last year from the group at Mayo, and it included about, I think, 90,000 patients at 3 different Mayo sites. And they looked at this, at switching from the race-specific GLI 12 to the GLI global equations, and what happened for specifically for FVC. So for FVC, you can see for Caucasians, the percent predicted increased, and also for Northeast Asians, but for mixed and other Southeast Asians and Black, there was a decrease. And for the white group, there was a 4.5% in the mean FVC percent predicted increase by 4.5%. So you can see why our patient went from being abnormal to normal. And so this has also recently been reported by the group at Johns Hopkins, and they asked, well, does a normal FVC, using the current race neutral reference equations for spirometry and race and white equations for lung volumes, does a normal FVC still rule out restriction, i.e. a low TLC? So they looked at 86,000 patients, and patients had to have an acceptable and repeatable vital capacity of TLC, and the prevalence of restriction was once again defined as a TLC less than the lower limit of normal, so it should be less than negative 1.645 z-scores. This was 35%. And the negative predictive value of a normal FVC to exclude restriction was overall 80.5%, not the reported 98%, 97.86%, whatever it was back in 1999 in that chest study. So, and there was significant difference in different races. And the conclusion was, well, a normal FVC does not rule out the presence of restriction. So this just shows you the variation of negative predictive value of a normal FVC to exclude restriction by race, ethnicity, anywhere from overall it's about 80% for the group as a whole, but for non-Hispanic whites, about 86, and for non-Hispanic Blacks, about 65%. So really the use of FVC will result in under recognition of restriction, especially in some racial and ethnic groups. So what is our protocol? Well, historically, we've had a protocol. So we've encouraged providers to say, you can just write for this PFT, quote, PFT protocol, unquote. And what did it consist of? Well, it consisted of spirometry, and then we would administer bronchodilator if the pre-bronchodilator spirometry is abnormal. They have a diagnosis of asthma, COPD, that's symptoms suggestive of airways disease. And we didn't do it if the pre-bronchodilator, once again, ratio was normal and the FEV1 was greater than 100% of predicted. So then we would do DLCO, and then we would perform post-bronchodilator spirometry. So we'd perform DLCO testing after bronchodilator was administered, that 15-minute waiting period, then post-bronchodilator if indicated, then lung volumes. But we'd only perform lung volumes if not only the forced vital capacity, but we would use VC max, so the highest VC. So remember, VC, you get several different VCs. Spirometry, you get a pre and post forced vital capacity, and you get an inspiratory vital capacity. And DLCO, you have a slow vital capacity. So if any of these VCs was above the lower limit of normal, then we wouldn't perform lung volume testing. We also wouldn't perform lung volume testing if VA was normal. So our protocol, now certainly people can order whatever tests they want. We don't exclude testing if people order that. So if a provider says, I want lung volume measurements regardless, I want bronchodilator testing regardless, they can order those. So you can either check the PFT protocol box, and when this is done, or you can order each test individually. So we've changed this. Now we've added a caveat based on the recent data that you consider ordering lung volumes, either plethysmography or nitrogen washout, if a low TLC associated with a normal vital FVC will affect your management. Now, I'm not sure it does. There's a few situations where it might, and maybe we can list those, but in general, probably not. And we think this really significantly improves patient management. Now, I will acknowledge that our sequence of testing is different than what is recommended by the uh, ERS ATS standard. So they recommend spirometry, lung volume testing, and then administration of bronchodilator, then DLCO, then post-bronchodilator testing. Now, this is problematic if you're doing nitrogen washout because you have to wait a significant period of time before performing DLCO testing if you use nitrogen washout because of the high FiO2s that are administered. So they recommend lung volume testing prior to bronchodilator administration, and certainly lung volume testing is affected by bronchodilator administration, and that may be important in a couple situations. I mean, one is trying to determine if a patient's a candidate for lung volume interbronchial valve placement, interbronchial valve lung volume reduction, in which case there's specific residual volume criteria that may be affected by bronchodilator administration. And they make no recommendation for or against bronchodilator testing prior to DLCO testing. So this is the way the ERS ATS recommends the sequence of testing. Once again, we do that a little differently by putting lung volume testing at the end and only performing it if restriction is suggested based on the reduced vital capacity. So next one, well, just back to the criteria for our other reasons to perform lung volume testing besides ruling out a normal or determining if restriction is present. And one of those is once again, determining if patient's a candidate for interbronchial valve replacement, which the two different valves, both require a TLC greater than the upper limit of normal and are greater than 100% and a residual volume that's either 150 or 175% of predicted. Now, there's also data that the inspiratory capacity to TLC ratio in patients with COPD is an independent predictor of mortality beyond FEV1, beyond, for instance, the Bode index. So there's some reasons to perform lung volume testing just for prognosis in patients with COPD. And also there's another study that's quoted, a study that looked at a VA population of patients that were smokers that did not have spirometric criteria for obstruction. And about 30% of that population, that subgroup, had evidence of air trapping, which they defined as an RV to TLC ratio that was increased. And those people had higher respiratory morbidity and mortality when followed subsequently over the next few years. So you can make an argument that lung volume testing has a purpose other than just ruling out a restrictive ventilatory impairment. And certainly our lab will perform lung volume testing, and if you ask for it, we will do it. But we prefer just performing are asking for our protocol measurement, our PFT protocol, because we think it improves lab efficiency and likely doesn't adversely affect patient management anyway. So just to kind of switch gears, what about MVV? Should that be routinely measured? And so MVV is one of those assessments of respiratory muscle strength, and that's really important in evaluation of patients with neuromuscular disease, people with unexplained shortness of breath, subset of those, and unexplained decrease in vital capacity. But MVV is highly effort dependent, is influenced by factors other than respiratory muscle strength, airways resistance, et cetera. And MVV is generally reduced in proportion to vital capacity in patients with respiratory muscle weakness. There's a reference down here that documents that. It's a difficult test and strenuous test to perform and likely adds little to basic spirometry, and we don't think it should be routinely performed, although some labs find utility in doing that. So, to conclude, running an efficient and effective and a good pulmonary lab really requires time and expertise. And if you are a lab director, you need to be allotted the time to run a lab effectively, and that's sometimes now not always the case, and especially in many community labs. Okay, I think we're open now for questions.
Thank you, Matt and or Dr. Hegewald and Dr. DeCato for this excellent presentation. Being there for several years on the PFT lab, I recognize a great overview of very practical things that happens every day. So I assume this was very useful for the more than 600 people really attending this webinar. I see already more than 10 questions, so I read them for you. I think you can see them. You can pick one of you who will answer the question. I will start with the first one. Do you have any recommendation or updates regarding worldwide PFT lab accreditation, like ATS, ERS, SANS from Australia, and etc., etc.?
I can start with that one, I guess. I don't know currently what is going on in Australia or New Zealand, but I have heard that they certainly have more of a process in place than we do in the United States. The ATS had previously been working on this, and in part, that's the idea behind the ATS lab manual, is that everyone has these same policies and procedures and ideas behind managing a lab, and that would eventually lead to accreditation and maybe working with the American Association of Respiratory Care. So that was a project that was ongoing, and then the COVID pandemic happened, and it came to a halt then, and I don't think it's going to be picked back up in that same way. I don't know anyone that's working on that again to sort of have formal accreditation of labs in the US at least.
Okay, thank you. Another question, I recognize two questions from the same person, and so I will ask them both. Which reference equation do you recommend for patients who are undergoing stem cell transplant? And the same person also asked, how do you recommend determining which appropriate reference equations you will use for your patient? And then she, of course, she explains she works in the cancer hospital.
Yeah, I can handle that. So really, it's less important as to what reference equation you're using, more important as to, obviously looking for a diagnosis of obliterative bronchiolitis. And what's more important is having patients serve as their own control. So performing testing prior to transplant and then comparing the most recent guideline statement on bronchiolitis obliterans, the BOS syndrome, recommends testing, routine testing, I think at day 100. And so we see a lot of those, and we compare it to the previous. Now, an important point when you're comparing to the previous value is especially in this population, is adjusting for hemoglobin. Now, we also adjusting your DLCO for hemoglobin. We also, where we are at, we adjust for barometric pressure, because we have labs at various different, people are familiar with Utah, from Park City, which is a higher elevation than Salt Lake City, than in southern Utah. So we'll have patients from all those, and it's important to adjust your DLCO for altitude if you have different barometric pressures. Now, the other thing is adjusting for hemoglobin. Now, what do the guidelines recommend? Well, they recommend, and I don't agree with this, they recommend you adjust the measured value for barometric pressure, but you adjust the predicted value for hemoglobin. So they give hemoglobin adjustment equations, and they're also in the the software, and the various manufacturers provide that. But we don't agree with that. We think it's hard looking at the adjusting. We don't adjust the predictive value. We adjust the measured value, which is not consistent with the guidelines for hemoglobin, because it's hard to compare a a pre-transplant with post-transplant DLCO in when you adjust the predicted value rather than the measured value. I don't know if that makes sense. So we use the same reference values, but more importantly, we compare the patient to themselves pre-transplant and adjust for hemoglobin.
Okay, thank you. I recognize from the company we put everything in according to the guidelines. This is what we have to do, but it's good to hear from you what is your practical solution by correcting this by hemoglobin and that by the reference equation. So I think that's why it's important to have this kind of webinars to hear really from the field what is the solution, keeping in touch with, of course, the guidelines. Next question, also from the same person. Your opinions about the advantages to use race neutral references. I wonder if there are really advantages listening last week or 2 weeks ago to Nirav, but it's good to hear your opinion, and from the same person, what is the difference between Caucasian and race neutral? I think one of you already touched this a little bit in your, but I think it's good to repeat your opinion.
Yeah. Yeah, Dr. Hegewald had a slide showing sort of the differences, the change in, I think it was vital capacity based on the races from GLI. So white, black, Northeast Asian, Southeast Asian, or other or mixed, to then using a race neutral equation. There's been a fair amount of data on this topic, and that's sort of what led to that 2023 statement of we recommend a race neutral equation. People have looked at mortality, and more recently, there's been some studies that have looked at, I think, clinically relevant outcomes. And so there's a study published in Chest in 2024, so just last year, in COPD population. This is another study that came from Hopkins, and they looked at percent predicted and applying Z-score and change in severity of COPD using under race neutral equations. And so using percent predicted, there was going from race specific to race neutral, there was significant changes in significance of lung function impairment in COPD. Whereas when you use Z-score, there wasn't that difference in race, and they showed that Z-score severity under race neutral equations better predicted exacerbations and hospitalizations. And so I think we're starting to see more evidence of race neutral equations and why they might be better. But you know, when you're doing an occupational evaluation, so the the Dow paper from the New England Journal in 2024, it looked at insurance, VA disability money here in the US. It looked at firefighters specifically, and so so it depends what you're doing, I think, with your PFT, but it's certainly an issue that we're gonna learn more about, and there will be will likely change in the future, in the near future.
Okay.
I'm not sure that answers the question very well, but it's an ongoing issue, I think.
Do you want to add something, Dr. Hegewald?
No, I think that, yeah, I think we need, so many papers written on this, and need further study. But it's pretty clear the current guidelines recommend using a race neutral reference standard for spirometry, and that's what we've switched to. It's an issue in our population because we have very homogeneous population in Utah. It's almost all white, and so we switched, and but there was some pushback based on our population, but anyway, we have made that switch too.
Yeah, and listening to your, of course, presentation just a few minutes ago, I was wondering, like, are you now recommending in Caucasian people who are borderline FEVC presented to predicted to always measure a total lung capacity?
Yes,
That
yeah,
that was a little bit my conclusion. Of course, coming there, that it was always the other way around. But now this is what I got from your presentation.
yeah. No, I think so. And people saw Neurov's presentation 2 weeks ago.
Yeah.
He really pushed back and said, does TLC really does having that TLC measurement does it really affect patient management? And he postulated no. And I think that that's a matter of debate.
Yeah. And again, that's very good, very luxury from our side to hear all you people really much involved in patient listening to you in this kind of educational webinars. The next questions, which I really are interested in, are what are your recommendation in acceptable differences when you do biological quality control on different systems? I translated from the same systems with the same goal. What are the acceptable difference between these systems? Being a little bit involved, of course, in our own studies, we all sometimes struggle with this.
That's a very good question. So, a couple things, a couple practical issues. Well, first of all, we have uh, three different body boxes and diffusions instruments in our lab, and I test myself, every 1 to 2 weeks on each one of those, and I am different in different, uh, a little bit different in different instruments, and our Excel spreadsheet gives you the results for each instrument, not between instruments. But I do notice there's a difference between instruments. I'm always a little higher in one instrument than the other. It's I think it's certainly within usually within two DLCO units. But I think the practical matter is that when we test a patient on one instrument, we test them subsequently on that same instrument. Uh, and so it's especially like, for instance, the bone marrow question. We once again, I'm a little different between in the different instruments, and the so we test the patient between using the same instrument. Now, we have looked at long-term variability, for instance, in diffusion uh, within the same instrument, but we have not done that with between instruments in our lab. So and I'm not aware of that data being published. I don't know if Herman or Tom is, but I think the take home is that there are differences between instruments. I see it when I test myself, uh, and for that reason, we try to test the patient on the same instrument and subsequent testing. Um,
I did it for a long time in my own hospital when I was still working, and I think you are also like with your answer, you will always find a difference. And then we've tried to find within a company if we do in our studies. So that's why people say, oh, you should do this number, this number. So of course, I'm always happy with your answer, but and of course, the most best way is to keep patients on the same instruments when you do trending, but practical, it's not always this easy. And ideally with the same PFT technician, etc., etc. But this is not the real world setting, I think, or almost not doable. But thank you for this question and thank you for this answer. What about bronchodilation response even when the FEV1 shows no need? Some providers insist in using to do this test and you show some change. I think the question is, what is the consequence of this results?
oh, so using probably if shows no need but provide assist on these. Uh, oh yeah. So, our lab, what we've done is well, first of all, if provider orders bronchodilator testing, regardless, we will perform it. Uh, Well, actually, that's not true. We don't perform it if it's above. Our protocol is if your ratio is normal and your FEV1 is above 100%. Now, sometimes they get done, and we have seen some bronchodilator response, and very rarely in patients that meet our criteria for not performing bronchodilator testing. Now, I would posit that you can make a strong argument that bronchodilator testing is really not important at all, because it's not a stable phenotype. It switches back and forth. The famous I'm blocking on the study, but the initial COPD inhaled steroid study did repeated bronchodilator response tests. Now they use the old criteria, 12%, 200, but people changed. There's this famous slide showing how 30% of people changed from one visit to another, from being responsive to not being responsive. And once again, the controversy about how you define bronchodilator responsive testing. Some people don't agree with the current standard, and how you use that clinically is another matter. But our lab does not perform it if it's above 100%. No obstructions not present. FEV1 is above 100% in general. But well, we understand that's controversial. And I guess if people really want to perform bronchodilator testing on everyone, I mean, the downside is that if you have a busy lab, and it increases the time commitment by, at least, 20 to 30 minutes. So it decreases efficiency and increases costs. And when we have busy labs where we have a hard time getting everyone in, that's problematic. And I think the overarching, picture is that most people, if you look at big studies of COPD in the United States, and less than half the people that have a diagnosis of COPD, quote diagnosis of COPD, unquote, have spirometry performed. So spirometry is horribly underutilized, and we need to do more spirometry testing. And an impediment of that may be just routinely performing bronchodilator reversible testing, which decreases the efficiency of the lab and decreases the number of patients you can test. It's kind of a long-winded answer, but I don't know.
I recognize Dr. DeCato is agreeing with you. So
Yeah, I am.
my small
Yeah.
question would be: is there a difference between children and adults? Because again, 10 years ago when I was the pediatric physicians really wants me to do in every child bronchi, and then we agreed, oh, we do it the first time, and when there was no response, and with your criteria, we didn't have to do it a second time. So we put one argument extra. Do you think there's difference between children and adults with your rules doing bronchodilation response, yes or no?
I don't know that, I don't routinely test children.
Oh.
I don't think there's a robust literature base with children and the utility of bronchodilator testing, as far as I know. But Tom, do you know anything more about that?
No, I can't speak more specifically to it. I do think, yeah, I just in general don't find bronchodilator responsiveness to be that useful. Maybe sort of an exception, regardless of your baseline pulmonary function, is or in folks with normal lung function, and you're suspicious of asthma. I think it's worth doing then, because you might show airflow variability, and that can help you in your diagnosis. But yeah, I don't think it's really that useful based on more recent data.
But then you can also ask patients always to come on their optimal medication. So then would this be that oh, when you're using this daily medication, this is how I want to do the second time, the next time on the PFT lab, the status of your pulmonary function, lung function on the optimal medication. And then even this bronchodilation test is maybe even less useful. But let's go on to the next question, which I like all the questions. Do you think bronchodilator affects diffusion capacity? So it's more the question, should you do it before, after, whatever?
Yeah, that has actually been fairly well studied, and it has small. Well, first of all, diffusing capacity, as we know, is such a quote noisy unquote measurement with lots of variability, and uh, the bronchodilator has small effect. It's like less than 5%. So there's actually been a number of studies that have looked at that, the effect of bronchodilation on DLCO measurement is small, and the guidelines say, well, you can do it before or after with not much effect.
But then I assume what you said, you keep the patient on the same instrument. If you do it always before, always after, then you should make this practice on your PFT lab. Do you also perform lung volume testing post bronchodilator, including about IRA resistance?
Yes, yeah. So no, good question. Bronchodilator testing definitely affects airways resistance, and it definitely has effect on lung volume, static lung volume measurements, and that's why the guideline statement recommends performing lung volume testing prior to bronchodilator administration. Um, Once again, we don't routinely do that because we exclude lung volume testing in patients that generally have a normal vital capacity or normal VA, as we discussed. So if you're looking at a specific change in airways resistance uh, as a response to bronchodilator, then you certainly should. So we have a couple of providers that always request lung volumes before and after bronchodilator testing, and we do it. We wonder what they're using that data for, but that's there it is true bronchodilator testing will affect airways resistance and oftentimes significantly. Remember methacholine, the old guidelines recommended it was a 20% change in FEV1 or a 35% change in specific airways resistance. But that's a whole separate discussion, measuring airways resistance and measuring specific versus just because airways resistance high depend on the lung volume which is performed. So big question. It does affect lung volumes and airways resistance, no doubt about it. And if you're using that for a specific clinical purpose, then you'd want to do it either, know exactly how lung volume testing was performed before or after bronchodilator testing. I would kind of ways maybe what's the clinical utility of that. Um, but that's, definitely a true statement that lung volume testing affects measurements of airways resistance significantly.
Okay, next question. I think you touched it already, so I think you can. It's about biological quality control, DLCO tracking, and if you do it on different altitudes. Again, I'm from the Netherlands, everything is on sea level or even below. But the question would be, does the altitude or the barometric pressure influence your DLCO? And I think the question, the person who asked already recognized it does. And from which altitude already you think there is impact on the DLCO? I shortened the question a little bit, but I
Oh,
think this is the
yeah.
main point.
Well, Tom and I published a paper on that a few years ago. We tested normal patients and COPD patients in um, a hyper/hypobaric chamber, and there's significant effects in DLCO across the barometric pressures. And the other thing to remember is that the inspired O2, the FiO2, also significantly affects DLCO. So if you're measuring DLCO in people on supplemental oxygen, you want to remove their supplemental oxygen. It's kind of the same principle. At least 15 minutes before testing if that's safe to do. So significant effects. Now, the nice thing about the instruments are the instruments have very accurate barometers. They measure barometric pressure and they adjust for that. If you can turn it on or you can turn it off, the software it's great. It'll adjust for that. Now, what we used to do in Utah is we used to use a 25 percent FiO2, which would give you a similar PiO2, partial pressure inspired oxygen, to sea level. But we don't do that anymore because the Salt Lake, and like I said, there's various altitudes. I mean, our health system has hospitals and that range from essentially, 1,000, well, whatever, from roughly 1,000 feet to over 5,000 feet at labs. People get tested in those. So we adjust. It's easy. The adjustment, thank goodness for the manufacturers. Their barometric pressure measurements are good. They're very accurate, and their adjustments are spot on. So that's it.
Of course, very happy with your answer. And I can only say we did the same, of course, in these pressure rooms. And I also, although again, I'm from the Netherlands, we did in Germany, even on 500 meter, it already had, we are not doing something in feet, but in meters. But at 500 meter already, you saw a little increase in DLCO, and with adjustment, it became a straight line. So happy, very happy that you confirmed this as well. Another question, what causes some individuals to have a normal TLC but a low residual volume?
That's a good question.
Normal TLC, low RV.
Yeah.
Yeah, comedy
I
thing.
think, well, when I'm reading in the lab with fellows and they sometimes point out things like this, and the thing that I talk to them about initially is, well, is it a good test or not? And that's sometimes hard to tell, particularly with plethysmography and what you have immediately available to you on your report. So always checking the test quality, which is easier said than done sometimes, for sure. And then, it depends, I guess, how you're defining a low residual volume. So are you saying 80 to 120% is normal for everything, right? This is sort of more of an outdated approach to lung function, I think. And so, is it less than the fifth percentile, 1.645 z-scores, then yeah, it's low. I'm not sure I have a great explanation for normal total lung capacity with a low RV, other than oftentimes when I look at these things with the fellow and we look at the quality of the test, and then it starts to become clear that, oh, maybe it wasn't the best test, or the quality is questionable, that sort of thing.
Yeah, and obesity classically, causes a reduction in ERV, and FRC less so is decreased. But if you look at the obesity studies, boy, they're all over the place with regards to RV. So some show that RV is increased, some show that RV is decreased. So obesity is one thing that can decrease RV, but that's highly variable. And then you know things like some of the things that don't do it are things like neuromuscular weakness, where RV is disproportionate. It's one of the indications for lung volume testing is you can get a physiologic diagnosis. So, usually if, for instance, TLC is low but RV is high, that really suggests either poor performance or neuromuscular disease, for example. Usually things like parenchymal lung disease, the RV and TLC are reduced in the same proportion. So that's another argument is we all have examples of these various lung volume measurements, TLC and RV, in various physiologic states like neuromuscular disease and obesity, et cetera. But the one thing is obesity highly variable, but can do that. Neuromuscular disease should not do that. Poor performance certainly could do it also.
So always check the quality. What with the mixing of ratio cultures, what ratio demographic should we use? I noticed that they differential vary. I don't know the question, but I have the feeling we don't need to use them anymore.
Yeah.
Yeah, I think that's our best understanding currently, is that we don't need to, and we can use race neutral, quote,
Yeah.
race neutral equations. We call them race neutral. There's only certain groups of people that were included in those studies, so it's not really representative of the whole world. But yeah, and certainly there are people who have mixed race or ethnicity background, and that certainly hasn't been studied very well.
Yes, and then
This
that
was
we
also, yeah, sorry.
Yeah, there was one of the problems we had was, before you would ask people what if they were in the categories of white, which include Hispanic, Black, and then Northeast or Southeast Asian, and we'd ask, Asian people if they were Northeast or Southeast Asian. Their answer was, well, I'm from San Francisco. I don't know what, that we're Asian, and it's basically quite a difference between whether you're north or south of a mountain range or this Pacific River in China. So it's so much easier now having race neutral. You don't even need to ask that anymore.
We have 15 minutes or a little bit more than 15 minutes left and still a lot of questions. So let's see what we can do in 15 minutes. A CPAT question, do you suggest MVV previous to CPAT?
Yes and no.
Okay.
No, I would say no generally, for the majority of folks. I think when I find it useful is if a patient's being referred for and there's a suspicion or a diagnosis of neurologic or neuromuscular disease. And then there's a little bit of data maybe in obese populations, but we use it to then evaluate what we call breathing reserve at the end of the test, and that's a crude measure when you get down and look at it. It's sort of a crude measure, and often there's subtle other constraints in ventilatory mechanics and things that you can pick up when you do inspiratory capacity with testing. So I typically use the indirect MVV FEV1 times 40 or 35 if you choose. That's just my opinion.
Another question. Do you have a good idea how to train new employees on the techniques of pulmonary function techniques? So as a PFT technician, being international, being from the Netherlands, I recognize in the Netherlands we have 3 years education. I think in the UK it's also the education with really that you get a diploma at the end of 2-3 years education. But I think these two countries are a little bit an exception in the world.
Yeah.
So you train your employees by yourself.
Yeah, there's certainly in the US, there's just a lot of variability in this. And we have respiratory therapy students come through our lab, and they spend very little time as part of their education in the lab. But we rely, I think, on the senior folks in the lab who have been there and are expert over the years in this. And I can't say that we've trained one person recently and we didn't train them for 12 months. I think that's probably unnecessary for most people. Again, that reference that gets cited still to this day is from the 1980s, and I think instruments have come a long way since then, for example, and so probably not that much time is needed, but I'm not sure I have a great answer to this question either. I try and do, and I know Dr. Hegewald does too, education for the staff. So sort of continuing education, so to speak, just for the lab staff, where we go over certain topics, certain things on a fairly regular basis as well. I don't know if you have anything to add, Dr. H.
Yeah, sure. Ongoing quality review. I mean, I review all the tracings, and
Yeah.
and then I mark them and say, hey, what do you, what happened here, and talk to them and get feedback continuously.
Can you comment how to assess the quality of specific airway resistance? Do you grade severity or impairment of specific airway resistance during your body plethysmography measurements?
We used to provide that. Well, it's obviously on a report. We get it measured in our equipment, and we don't currently comment on that. Maybe that's a shortcoming of our lab. I know that is there's a lot of variability amongst labs whether they comment on that. It's if you look at the range of normal for airways resistance, it's really quite wide. And then you certainly have to measure specific airways resistance and specific conductance because it's so dependent on lung volume. We do not probably, should we? I don't know, maybe.
We don't either. Yeah.
No. I feel we should do another webinar also about our resistance volume graph. I'm still wondering why this is not that much accepted as the flow volume curve, but this will be another topic in another webinar. In the
Yes.
Netherlands, biological quality control, I know the question is by law forbidden about the amount of gas you're inhaling. And I was the one who tried to promote this in the Netherlands, do this every week, every month, and then people also came to me, oh, we are not allowed by ethics to inhale this much of gas. Do you see this as well?
I can come into that. I mean, I'm our biocontrol, and I think that's a good question. I mean, you cannot do, that's one of the issues. You cannot test yourself on, we have, once again, 3 different DLCO machines, and you can't uh, do testing over a few hours, 6 to 10, 12 tests over a short period of time. You start to develop your carboxyhemoglobin level increases as if you smoke several cigarettes. So I test myself on one instrument, wait, test myself another instrument, do things in between. So I test myself. Yeah, that's because I know I'm going to be around, and I know when I'm sick and not sick. I know that's probably not the most efficient use of my time, but I enjoy doing it. They're correct. You can't force your lab your lab personnel to do that. You have to have volunteer.
Yeah, I'm also the biocontrol in our hospital lab because it's on the smaller side, but I don't do the biocontrols in our research lab, which is a little bigger, and we have other staff available.
Whenever you receive an order to an isolated long volume measurement, do you perform them or you add other control tests like spirometry? In my experience, long volumes by themselves add very little. So it's more like, do you see the
Uh,
use of only measuring long volumes without spirometry or diffusion?
Oh, that's a good question. We get both of those. So there's providers in the community that just have a spirometer. So they'll perform spirometry and they'll say, well, boy, body capacity is low. I better confirm it. So they'll send them to our lab for lung volume testing. And we do that. Yeah, the question is how clinically useful that is. Now, before we do DLCO, we always perform spirometry because you need that as a quality measure to make sure you're uh, because we'll get the same thing, people just for DLCO, but we always perform spirometry before a DLCO because we need to determine if our inspiratory vital capacity meets the acceptability criteria, i.e. 90% of a subsequent vital capacity.
Due to the time, I continue with try to do a few. What are your suggestions for how best to interpret FVC using GLI global predicted values and reduce TLC using GLI Caucasian? So if you take the reference from one set and the reference from the other set.
Yeah, good question. Yeah, no, how do you interpret that? Yeah, I don't know. I think uh, you can ask 100 different, labs in the United States and you get multiple different answers. Good question, how to do that. By definition, a low TLC is, like if you look at the guideline statement, a low TLC defines a restrictive ventilatory impairment. Um, but Nurev discussed that just 2 weeks ago, saying that he doesn't believe in that, and I know other labs don't. So it's a good question. No clear consensus about that.
And when you perform biological quality control, are you concerning what is it, privacy, or how do you deal with the data? Is it performed on voluntary? I hope so. I assume.
Yeah, good questions. You have to have somebody who voluntary wants to do that.
You cannot push, of course. Also a good question. Are there any new upcoming technologies in PFT or maybe CPAT that you foresee as being a game changer Do you see something, but it's a little bit out of the scope of the webinar, but I think, do you have a quick response that you think this is what's new?
Yeah, well, iOS always comes up.
Okay, now I was even wondering these kind of things.
Yeah. Tom, what are your thoughts?
You can also choose one.
Yeah, oscillometry has kind of been threatening to be that for years now, so we'll see. And I think we will. We didn't talk about this today. There was a question about MVV and CPET, but I think we will see sort of advances in CPET in the near future.
But
That
I
make it a little
recognize
useful.
that I feel you say, oh, iOS is already promising for a few years, but still not doing what you
Yeah,
expect
well,
a
I
few
think
years
in the
ago.
US at least there are some big, large academic labs that use it, but it's not routinely used. Otherwise, I would say, I
No,
don't know if you think that's fair or not, Dr. H.
no.
Yeah, yeah, certainly.
I recognize they are not, it's not yet in the global recommendation to treat asthma and COPD. It's still spirometry. So I was checking if it was there, and that's what I found. But new one. This is also a very nice question, also from one of the colleagues from the Netherlands. What do you think of doing DLCO simulation with the Hans Rudolph? Are you using the Hans Rudolph simulator?
Oh yes, we are. It was Bob Crape and Bob Jensen for our lab hold the patent for that. We have multiple ones. Yes, we do that. We didn't mention that most labs don't have it. It's another great way to it really is the gold standard for testing a lab. Uh, your quality control of your instrument. Uh, we also have a waveform generator to for testing spirometers, but those aren't most labs don't have those.
But you are using it. Uh, do
Yeah.
you think, like, for the future, you recognize in the new guidelines of long volumes, now they recommend the ITGV simulator. Is
Mhm.
it fair to think that also if there are any new guidelines for DLCO, that then there also will be a recommendation of DLCO simulator testing? What's your opinion there?
Yeah, I think, but I think it's not gonna. I think it's gonna supplement biocontrol testing. Because remember, biocontrol testing is more than just making sure the machine works. It's also testing the technician, the consistency of the technician, and other things too. So I think it supplements that. And it's a great. We have multiple ones, and and I'm sure, Bob Jensen, who's in Utah, would love for everybody to get one because he gets a royalty every time one's sold.
Okay.
Yeah.
What about Saudi Arabia reference equations? Do you know something about this? Do you have recommendation? Do you know that they exist, or should they also use the global ones of GLI?
There are limited, Persian reference standards, and the that are dated. Now so GLI other is great. Our GLI global is great for that. That's what we use.
I just read them for you, just a few of them. If the patient is already on maintenance respiratory inhalers and rescue inhalers, and they took it prior to testing, do we still do a post spirometry? It was more my question in the beginning. Or just pre, or do you label this as a post test?
Yes, that's a good question. Tom, do you want
Yeah.
to?
Yeah, when I have new patients come in for their first PFT, they're referred to pulmonary, maybe they're for whatever reason, but they're already been prescribed inhalers and using them. I try and have the patient stop and get baseline lung function without inhalers on board. And then usually for repeat studies, if I think they require or benefit from that therapy, then do repeat testing on them. But what we do in our lab in those circumstances is we just make note of it. Like the patient took albuterol 2 hours before coming to the lab today. And yeah, it kind of depends maybe in my case, which fellow's in the lab, because usually the staff will go to the fellow and ask them, okay, should we do another bronchodilator and do the post-BD spirometry or not? And so sometimes it happens, sometimes it doesn't, to be honest. But then when I'm interpreting them, I know, okay, when did they last use inhalers? What did they use? I have that information.
Yeah, so we do the same. We perform testing with bronchodilator, and one of the arguments would be, well, most people don't use their bronchodilators effectively anyway. So even though they said they used it, maybe it's not. We just look and see. It's important to know maybe they have additional bronchodilator responsiveness on top of their other bronchodilator. Yeah, I think you can go either way. Recommend holding it for the initial testing, but if they didn't, we will use it. We will get administer bronchodilator. Now, once again, the technician will often say, or the patient will say, I just use this in my car before coming in, and the technician will say, we like to not to test it because they just used it or something. But we don't have a standard. Probably should, but generally we repeat bronchodilator testing, even if they have used it within the allotted time period of the duration of effect of their bronchodilator. But you can go either way.
I pick a last question because it's time. It's 90 minutes after the start of it. Again, I apologize. We could not answer all your questions, but it will for sure encourage us to ask this to medical doctors again somewhere, maybe this year or for sure next year, because I see there's a big need for this kind of presentations. Maybe you read the questions. Maybe you can either pick one of them which you'd like to answer. I think this makes most sense, and then we will close the webinar because we have to stop somewhere, and we can.
Well, I can talk about the hemoglobin one because that's funny. I just queried a bunch of the experts in the field about what they do for hemoglobin correction of their DLCO and whether or not they routinely measure hemoglobins to test how long they wait. Now, I know Dave Kaminsky, his lab does it within 6 weeks, looks at a hemoglobin within 6 weeks. The Hopkins lab, they don't routinely adjust, although they do have a point of care system. They can adjust hemoglobin. So a lot of variability. We use 3 months hemoglobin the last 3 months, unless they're a bone marrow transplant or oncology patient, we use 1 month. Now that is, I don't know where that comes from. A lot of variability in that, and it's funny that question is asked because I just got through asking. A lot of variability in whether or not you should measure hemoglobins, and if you have an active smoker, the other issue is whether you should not measure carboxyhemoglobin to adjust your DLCO.
But I recognize, sorry that I enter that at the moment you can have a finger puncture and you have in 1 minute your hemoglobin. It's not from our company, but why not? And you can in our I think in most softwares, but for sure not, you can add it then. And even in the 4 minutes waiting time, you have your most recent hemoglobin. So why not?
Yes, yeah, that's what Hopkins, like I said, they have that, and they don't use it. They have it available, and they use it only for oncology patients. I just their lab this week. Yeah, so there's no consistency amongst the major major labs, yeah, in the United States.
Last question, Dr. DeCato. Do you recognize one you like to answer?
I
recognize also a lot of double questions which are already answered.
Well, I guess the one at the top here is, I would like your opinion on the role or the difference between reference values, GLI global and GLI lung volumes on the differences in FVC and TLC. I mean, can the problem be related to the reference values? I think, yes, part of the problem, what Dr. Hegewald showed is we used to think, okay, a normal vital capacity does a pretty good job of excluding restriction by lung volumes. And now we think not so much. And that is certainly a product of, I think, new reference values and going from race specific to race neutral. And so if we had lung volume equations that incorporated more groups of people and were on the vein of race neutral, like for spirometry, would we see less of that? It's certainly possible. maybe it's not an obvious thing, but it's really hard to do these studies and to get reference values. And so I don't know if we'll see that or not. I'm not aware if GLI is working on that or someone else, but.
Okay, thank you for this excellent webinar, and I for sure we could go on continue for another 1 hour because we still have 55 questions, or also people who say thank you for all this nice information. And again, it will encourage us to do even more of this kind of webinars with people like you. I think it's very important to educate everywhere and help to answer the questions, and maybe we can do something with white papers to answer some questions. But for now, and there are still more than 400 people on the phone, thank you for being this long with us. There is also a recording, just so you can see the recording back and listen again to all these nice and clear answers. Having said this, thank you again, and check our website or the social media, because in, I think, 1 month, Dr. Daniel Dumitrescu, one of the key speakers of the Wasserman Group, will also guide you to CPAT interpretation, also by a webinar like this. Thank you, Dr. Hegewald, Dr. DeCato. We will have contact. And by this, I have to close it. And enjoy your day or evening when you are in Europe or wherever you are. Thank you for attending, and hope to see you in our next webinar with Dr. Dumitrescu. Bye.
Thank you.
Thank you.
Thank you.